In this image, we observe two X-rays of a child's chest showing a circular radio-opaque object lodged in the upper airway. On the left side, labeled A, the object is in the upper esophagus, suggesting ingestion. On the right side, labeled B, the object projects over the trachea, indicating aspiration. These radiographs highlight how an inhaled or swallowed foreign object can appear differently depending on its position. Identifying the correct location is vital for planning safe airway management and intervention. This is a 2-year-old girl who presented with sudden onset coughing and choking while playing with peanuts. She has persistent cough and a unilateral wheeze without fever. Her oxygen saturation on room air is 92%. The chest X-ray shows hyperinflation of the right lung and mediastinal shift, suggesting a one-way ball valve obstruction. She is now scheduled for rigid bronchoscopy to remove the suspected foreign body. When a foreign body is inhaled, it can lodge at different levels of the airway. If it is in the larynx, it may cause complete obstruction and lead to asphyxia. In the trachea, it can cause bilateral wheeze and stridor. Most commonly, it lodges in a bronchus, especially the right bronchus, causing air trapping and hyperinflation due to a ball valve effect. This can shift the mediastinum and cause ventilation-perfusion mismatch. Over time, the airway can also become inflamed or develop bronchospasm. Clinical features. Foreign body aspiration typically presents with a sudden cough or choking episode. Stridor or wheezing may follow, depending on where the object is lodged. A unilateral decrease in breath sounds suggest a bronchial obstruction. Cyanosis and desaturation point to partial or complete airway blockage. Chronic signs, such as a persistent cough or hoarseness, may indicate an overlooked foreign body. Notably, chest X-rays can be normal. Additional imaging, such as inspiratory expiratory films or fluoroscopy, may be helpful. Challenges for anesthesia. Anesthesia for foreign body aspiration is complex. Children are often uncooperative, and crying can worsen obstruction. Many have recently eaten or swallowed saliva, increasing the risk of aspiration. The airway can become fully obstructed during induction or instrumentation. Because the anesthetist and surgeon share the airway, coordination is critical. Any movement of the foreign body can cause severe bronchospasm or laryngospasm, so the team must be prepared for sudden deterioration. Preoperative preparation. Before anesthesia, a full team briefing is essential. This includes the ear, nose, and throat surgeon, the anesthetist, pediatric intensive care team, and nursing staff. The child should be assumed non-fasted, and rapid sequence induction precautions must be in place. All necessary equipment should be ready: the rigid bronchoscope, various endotracheal tube sizes, jet ventilation system, suction devices, and an emergency tracheostomy kit. Emergency drugs such as atropine, adrenaline, salbutamol, and dexamethasone must be drawn up. Induction plan. Induction should be done using inhaled sevoflurane with 100% oxygen while maintaining spontaneous breathing. Muscle relaxants must be avoided until the airway is secured. The child should be positioned supine with the head slightly extended, but positioning may need adjustment if breathing worsens. Positive pressure ventilation is not recommended, as it may push the foreign body deeper into the airway. The key principle is to allow spontaneous respiration to minimize displacement of the object. Intraoperative management. Ventilation during the procedure can be achieved through the side arm of the bronchoscope, jet ventilation, or apneic oxygenation for short periods. Deep anesthesia is required, which may be maintained with intravenous agents like propofol and remifentanil or with volatile agents. The surgeon uses an optical forceps through the rigid bronchoscope to remove the foreign body. The team must be ready to manage airway complications such as laryngospasm, bleeding, or bronchospasm at any time. Complications. Common complications include laryngospasm caused by airway irritation and bronchospasm, especially after removal of the foreign body. Hypoxia can occur due to prolonged obstruction or apnea. Negative pressure pulmonary edema may follow complete obstruction. Pneumothorax or pneumomediastinum may result from barotrauma or instrumentation. Organic material like nuts can also cause aspiration pneumonia. Finally, airway trauma can result in bleeding or swelling. Key pearls. To minimize risk, keep the child calm, upright, and breathing spontaneously. Avoid bag mask ventilation until the airway is secured. Always ensure the ear, nose, and throat team is present with surgical airway equipment. Be prepared for bronchospasm or sudden oxygen desaturation. After the procedure, extubate only when the child is fully awake and provide postoperative care in a high dependency or intensive care unit.